I wanted to speak this morning a little bit about the international response to Ebola and how it translates to what we're doing in the United States and some of the challenges that you have faced and we continue to face here. This is sort of a disclaimer. I work for both the Centers for Disease Control and the U.S. Agency for International Development, the Office of Foreign Disaster Assistance. And if you speak on their behalf without their permission, they get really pissed off. They're the government, they know everything. So anyway, so this is in my role. I'm obviously drawing from those experiences, but if I say something controversial and obnoxious, it's me, not the government. So just with that preference, I'll start. I see people in the audience that have seen this talk several times, like, hey, so you could just leave because you've seen this. But anyway, I often start these talks with this quote from the International Committee of the Red Cross. And I think it's important because Ebola and similar things really was a big deal in the United States. And that's not to say it wasn't a big deal internationally, but I think when we look back, we're going to say, gosh, Ebola, that was it. That was the pinnacle. That was a big deal. That's the biggest thing that's happened. And internationally, these kind of things happen all the time. Maybe not a disease outbreak, but disasters. And so this is a quote from the ICRC, that disasters are all too often regarded as unusual events, not part of normal life. I apologize again about the fact that PCs are bad computers. In reality, however, the opposite is true. Disasters and emergencies are a fundamental part of normal life. They are consequences of the way societies structure themselves economically and socially, the ways that societies and states interact, and the ways that relationships between the decision makers are sustained. And in fact, in the last 10 years, there have been about 300 earthquakes with humanitarian consequences. So not something in the Aleutian Islands off of Alaska, but a significant earthquake where there's displacement of people and significant morbidity and mortality. There have been about 272 droughts, almost 1,700 floods with humanitarian consequences, and 52 wars. And these are the biggies. Outbreaks of infectious disease don't usually hit the radar of humanitarian response, but Ebola and now Zika to some extent have changed that. And the big question in the international community is this a blip or is this the new norm? And I think that remains to be seen. So I want to talk a little bit about the international response to disasters and sort of focus on the US government's role in that, because that's what I'm involved in. I work for the Office of Foreign Disaster Assistance, OFDA, which is part of the United States Agency for International Development. And it's located here in the Ronald Reagan building. It's interesting, Ronald Reagan, who was at the time the champion of small government, this is the biggest office building in the District of Columbia. Pentagon being technically not in the district. So, and to add insult to injury, 2 of the 3 big occupants are the Environmental Protection Agency and the United States Agency for International Development. On the good side, the Border Patrol is there too. So there's lots of guns, lots of jumpsuits, lots of people with patches and stuff. So, anyway, so I don't know what, I imagine Ronald Reagan is rolling in his grave for a variety of reasons right now, but this being one of them. So where I work is in USAID. There's a Bureau of Democracy, Conflict, and Humanitarian Assistance, and this is the entity that leads all international response for the U.S. government. So coordinates all the other agencies, State Department, DOD, CDC. We're really a coordinating entity. And I work in the Office of Foreign Disaster Assistance, and basically most of what they do, as you'll see, is coordination and funding of implementing partners. But there is a small technical assistance group, and I'm in the health group, one of the health advisors. There's about 4 of us at the time, right now. We have a bunch of regional offices, Bangkok, Nairobi, South Africa, Budapest, Hungary, Senegal, Dakar, and San Jose, Costa Rica. And we have specialists located in those offices that can respond to disasters immediately. So when Ebola hit, the folks from the Nairobi office were the first ones there because they were geographically the closest. There are some liaison offices because DoD is a huge player. They have capacities and capabilities that no other entity on Earth does. Their lift power and things like that. But their role in humanitarian assistance has been varied through the years. So they are a close partner to the point where we have liaison offices with Eurocom, Southcom, CENTCOM, and PATCOM. So there's some poor slob that has to work for the US government sitting in Honolulu meeting with PATCOM every day. So that's a tough assignment. We have commodities warehouses. There are actually 4 now, but the big 3 when this slide was made, Dubai, Miami, and Pisa, Italy. And as you can imagine, what do you need for humanitarian assistance? PPE, trucks, fuel, water bladders, meals, not meals ready to eat because that's actually food for peace, but pots and pans, things you would need in the first 24 to 1 month of a humanitarian emergency so they can be mobilized very quickly. And in terms of what they do, the most common thing is they give financial response or financial aid. And basically, you can give immediate financial assistance. So what happens is there's a disaster somewhere. There's a flood in Pakistan, and the U.S. ambassador to Pakistan declares an official disaster declaration, which is an official State Department mandate. And what that does is it opens up funds. So the ambassador to Pakistan can then literally write a check for $50,000 or $100,000 to his or her counterpart in Pakistan to help. So most of the responses aren't trucks and people and airplanes. Most of it is cash. And it's a way to sort of say, we're sorry that you're having a flood. The U.S. government wants to help. Here's $100,000 from the people of the U.S. to help you. So it's sort of like a get well card. And that's the majority of assistance, actually. That's the $50,000 get well card. But we also do a lot of funding of partners. So NGOs, international organizations, and UN organizations. So we don't touch patients, per se. I'm a physician, but in my job with OFDA, I don't touch any patients. We have implementing partners like International Medical Corps, Save the Children, things like that. So we provide the financial resources for them to get on the ground and do their work. And that's going to be important when we talk about Ebola, how that usually happens. When a disaster strikes, they deploy a disaster assistance response team. So when someone said, wow, Ebola is going to be a real disaster, we need to respond. The DART was formed from the Kenya office and went there. Back in DC, there's a response management team, which is sort of like mission control. It's in a building where in the initial parts of a disaster, there are people there 24/7 with computers and big TV screens, basically supporting the people on the ground with whatever they need, helping to get people there. In the early days of Ebola, because of the concern for being evacuated, everyone needed a diplomatic passport. So there were literally 4 people that were going to the embassy and getting everybody diplomatic passports and saying, here, get on the plane, here's your ticket, here's your passport. So there's sort of mission control. We can dispatch commodities, such as PPE, which we talked about, provide technical assistance, and that's sort of the role that I sit in, either to our partners or to US government or to countries. We were in Nepal in October of 12 working with the Nepalese government, developing a response plan if there were an earthquake in Nepal. And I was unfortunate. I gave this talk and we talked all about the Nepal earthquake 36 hours before the Nepal earthquake. So now I think, and the instructor, I saw him, he said, now we think you're some evil clairvoyant or something. But I'm not predicting anything. So those are the things we do. And when we talk about Ebola specifically, the DART team going out and trying to fund partners really becomes sort of interesting. So what normally happens? And we're going to use Haiti as just a generic example. This is the Ministry of Health, the Ministry of Public Health and Population, the MSPP in Haiti. So when a disaster strikes, the government is in charge. It is a sovereign nation. It gets a little tricky in situations like Syria, where we no longer recognize the Assad government. But in general, the government is in charge. They are supposed to run the show. And what usually happens is the first folks on the ground are often NGOs. And why is that? It's because a lot of these countries, these disaster-prone nations, are already very poor, very resource-challenged, and there are often NGOs already working there. So Save the Children, International Medical Corps, and Doctors Without Borders, MSF, were already in Haiti before the earthquake. They were doing other work. They were doing development work. The earthquake strikes, and they need to shift gears quickly and respond to the emergency. And then they eventually bring in their emergency players. But I was working, spent some time with Save the Children. I was working for CDC, but we were teaming with Save the Children, and all their development folks shifted gears and were doing emergency response. And eventually they shifted their team and got their emergency response experts in. But often these are the people that are really on the ground. This, and of course the Haitian people. The Haitian people picking up rubble by hand saved way more lives than a fancy urban search and rescue team. And it's not that I think urban search and rescue teams are fine, but I think they get a little disproportionate amount of time on CNN perhaps when you really look at who saves lives in these things. It's it's the population of the country. So often after that, international organizations, IOM, the Red Cross will often come in. The World Health Organization or the World Food Program, just sort of using those generically, but some sort of UN organization. CDC is always a little bit of a mixed bag because it depends on the nature of the emergency. After the earthquake, CDC wasn't needed immediately. When the Ebola outbreak was recognized, CDC was needed 3 weeks before. I mean, so it depends on the nature of the disaster. And then finally, funders. Someone's got to pay for all this. And so funders, USAID, UKAID, there's Aussie Aid. A lot of the Middle Eastern countries have supported, especially the response in Syria. So these are sort of, just to keep the slide relatively clean, these are just sort of representative. They're certainly not a comprehensive list. And so, normally Ebola was unusual. So that's the way things usually work. When an outbreak of an infectious disease happens, CDC, from the United States perspective, CDC has the technical expertise and capacity to manage this. CDC, when I was there was actually an Ebola branch. There was a branch within CDC dedicated completely to viral hemorrhagic fevers. It's since, when Tom Frieden took over, there was a reorganization, and now it's called the Special Pathogens Branch. But there's a group of people here that are experts in responding to Ebola, and they write the recommendations both for international, and as you have probably experienced, they wrote the recommendations for the domestic response in terms of PPE and things like that. So these things happen, these small Ebola outbreaks happen all the time, and these guys respond and they control it, and usually they kind of are, to some degree, self-limiting for the reasons we'll discuss when we compare it to the recent outbreak in West Africa. But when this happened, everyone said, okay, this is a CDC thing, no problem. And then what happened was it became very clear that this was not the usual Ebola outbreak. And it became clear that they needed to have a much bigger coordination framework to respond to this thing. And for better or for worse, I'm counting down now. Wow, okay, never mind. Don't be nervous. And for better or for worse, the answer to that was, well, OFDA does this all the time. USAID is our response framework. Let's do that. And so it was unusual in that now CDC and the U.S. Agency for International Development had to sort of work together. And it was, for me as a consultant who has a foot in each camp, it was really fascinating to see how these two organizations are so vastly different and how they operate and the lack of understanding of how they operate. In the early days of Ebola, I think that lack of understanding slowed things to some degree. So. And it really, in terms of the response in West Africa, there was such a concern that this was to come to the United States that it really became an all-of-government response, was what they were referring. So, the National Security Council and the White House were very concerned. Obviously, OFDA was involved, and this is our branch at CDC was involved. And then the Department of Defense, Health and Human Services because of CDC, the Department of State, anything that potentially could threaten the U.S. population. And so it was really an all-of-government response. And then, even FEMA was getting involved in case they needed emergency management domestically. So it was very different. And just to kind of give you, this is the latest. At September of 15, they sort of have stopped putting these out. But this was an incredibly, and continues to be, an incredibly expensive response. So, billions of dollars now. So. And some of that, of course, coming from OFDA, a lot of that coming from CDC. Food for Peace is our partner. We don't give any food commodities. We give non-food commodities. But Food for Peace is our partner also within USAID that delivers food aid. And then USA also has a global health unit. And then the country teams were also involved at the mission at the embassy. And so a little bit about Ebola. I don't know if anyone covered this, but it's sort of it's a fascinating story. Ebola was named after the Ebola River. They named these. Zika is named after the Zika forest. Ebola is named after the Ebola River in what, at the time in 1976, was Zaire. It is now DRC. And this guy, Peter PIOT, who interestingly is speaking in Seattle at the UW Global Health Conference. He's the keynote speaker later this month. It's probably going to be a fascinating talk. He was a young researcher in Antwerp, Belgium, working not on viral hemorrhagic fever, but the story, and we'll see, the story I've been told and that gets passed down, it'll be interesting to see when he speaks later this month, but is that he received a coffee thermos with a bunch of ice, a test tube full of blood, and a handwritten note that says, one of our missionary nuns died, this is her blood, we don't know what it is. And I'm sure he didn't put on PPE, I'm sure he dumped the thing out and held it up to light. And he put it under a microscope and he said, wow, that looks like Marburg. It looks like a viral hemorrhagic fever. And Marburg was the one that had been described at the time. And he said, but it's not Marburg, it's different. And so he decided, I'm going to go figure it out. And he literally, carted off to ZAIRE, and the rest is history. And he is credited for discovering or first describing Ebola. And sort of the rest is history. He went on to be he's a very prolific guy. It's not just on this, but he went on to be the president of the London School of Tropical Medicine and Hygiene, and he's a very very accomplished guy. The fruit bat is reportedly the vector, or the reservoir, not the vector. The reservoir, it's still a little bit unclear, but the fruit bat gets the credit. This Ebola outbreak was different than the others, and part of it was that it was fairly urban. When you look at the three countries, Conakry, Freetown, and Monrovia, there was a lot of urbanization. A lot of these in the past have been very rural, and there's just not enough population density for these things to take hold and go crazy. They sort of burn themselves out. And we all know, or you may know, this is the area where the three countries meet, and the first case, the index case, was a 2-year-old boy who died, and then his mother died, and then the doctor taking care of him died, and then it kind of took off from there. And why is that? Why did the doctor dying lead to sort of a dramatic increase in cases? Right. So his funeral, and what do people do at a funeral in these areas? Right. There's a lot of washing the body and touching the body, and that's it. Right. So that was sort of sort of where it really took off. Exactly. And as you see, when you look at the urban areas, the density of that really is mostly where it was. Again, it started out here in the rural areas, but this is probably the reason. There's some discussion that this strain of Ebola may be more virulent, but it's certainly somewhat due to the fact that this was both an urban and rural outbreak, and that was very different. And again, sort of the same thing, the darker, the more cases, and when you look at Monrovia, Freetown, and Conakry, the majority of cases are kind of stemming out from, or the density stemming out from there, because their population is dense. And this is again updated November of last year, but this is by far the biggest outbreak. Again, you can almost double these numbers now. They're about 9,000 deaths and 23,000 cases, but really the biggest outbreak. This is the initial one in '76 in DRC, then Sudan, when it was initially described. And this was back in in September. I'm sorry, September of last year. What's sort of telling about that graph? What sort of sticks out? Which one of these things doesn't belong, as my daughter who likes Sesame Street would say?
Nigeria?
Yeah. Why does Nigeria stick out?
Natural fuel?
Yeah, exactly. And why is that? So the case in Nigeria is interesting, and for instance, the case in Nigeria was a dual citizen, U.S. citizen from Minnesota, who was working for the Ministry of Finance in Liberia. Got sick, was told not to travel, said, screw it, I'm going back to Minnesota to get health care, which, I think on an individual level is a reasonable decision. Got on a plane, flew through Lagos, got off the plane very ill, and basically, was cared for and dropped dead. And all of the cases in Nigeria are directly tied to his care. The more importantly is, why didn't it take off in Nigeria? What's different about Nigeria? They squashed it right away. They
started in the urban area and had more access to care.
Yeah, well, right. They have an intact healthcare system. They have public health. They have surveillance. It's the three countries. These three countries are, even on the African setting, are very, very resource challenged. I mean, their health infrastructure prior to the outbreak was pretty abysmal. Yeah. So so I sort of would not chuckle, but when they said, "Oh my gosh, this is going to just spread through the United States like wildfire," it was really kind of lunacy. And I understand the panic and I understand the concern, but it really didn't make sense. I mean, the flu is way more dangerous than Ebola in terms of a threat to the United States population. And Nigeria is a great example that if you have an intact health system, you can really get on top of this quickly. So more updated, about 23,000 cases, almost 10,000 deaths. And so when we first started, the big challenge was safe practices and infection control. And that's obviously a challenge today. It's a challenge in the United States that we face if we have a patient who we suspect has this. And one of the challenges initially was evacuation. You know, we sent our DART team, and the DART team goes out, and they usually have lots of money, and implementing partners show up and say, hey, we want to do this or that. So in Haiti, IMC says, hey, we're going to set up a hospital. We've got orthopedic surgeons. You know us. We're a vetted partner. We need $2 million, and we can run a 60-bed hospital for 3 months. And the U.S. government says, go ahead, you know, submit a proposal. It gets technical review by our technical team, and we can move money relatively quickly. One of the differences about OFDA and other U.S. government agencies is their ability to move money quickly. We can literally mobilize money in 24 to 48 hours, so which you need to in these circumstances. Ebola was different. The DART team went out, and they showed up, and they're like, okay, $3 million, who wants to start an ETU, an Ebola treatment unit? And there was no one there, except for MSF, because MSF, to their credit, is everywhere. They don't take U.S. government money. They don't want to be, which is fine. I mean, they have enough private funding, and they don't want to be burdened by having the U.S. government tell them what to do. I totally respect that. We work closely with them, and in Ebola, we look to them, and CDC looked to them for guidance. But there were no partners showing up. It was very different, and it was literally because they were terrified of what was going to happen. And I was in D.C. at the time, and there were numerous phone calls from big NGOs, foreign NGOs, saying, well, if one of our people gets sick, is the State Department going to evacuate them? And what's the responsibility? And what's going to happen? And people were understandably terrified. And you know, one of the things, this is Phoenix Aviation, which is a Georgia-based. These are the guys that flew Brantley back to Atlanta, and they have this Gulfstream, and there are 2 of these in the world. And they've got the little tents that fit inside. And there are, I think, 12 of these tents in the world because, you know, they don't really need them. It's not like the company's building them as fast as they can go off the shelf. They don't go off the shelf. So I think there were 12 of them at the time. 10 of them were owned by the Centers for Disease Control. There are 2 of these airplanes. And so this is a very limited, valuable resource. And the discussion was, who do you use this on? You know, if MSF Belgium says, we've got someone who's got Ebola, is that our responsibility as the U.S., not the U.S. government, but the United States, is that our responsibility, or is that the Belgian? You know, these were very unclear. And how are you going to evacuate U.S. government folks? You know, the folks we were sending out with those diplomatic passports, you know, what level of exposure? My partner who went out, Justin, was in a meeting with the ministry and shaking hands and having tea, and then he finds out that one of the guys he met with died, you know, 4 days later, is dead from Ebola, and, you know, other than washing his hand about 60 times, he had to quarantine himself and take his temperature twice a day, and he's in Sierra Leone, and you know, do you evacuate him? I don't want to say waste, but do you utilize this resource? And it was really uncertain. There was a lot of uncertainty. The State Department immediately procured this asset, as they will tell you, which means they signed an exclusive contract with Phoenix Aviation, so no one else could touch it except for them. So it was under the complete control of the Department of State. But you know, we had discussions about what risk exposure do you use one of these. I mean, someone obviously has Ebola and they're not going to do well in country. Yeah, fly them out, like the case of Brantley and the other Samaritan's Purse employee. But what if someone, you know, gets a blood exposure? At what level? And these were very real issues. And at one point, you know, the State Department physicians said, well, we've got contracts with other air ambulances to do the people that are exposed that aren't sick. And at that time, and it still is true, you know, they said, well, if they don't have a fever, they're not contagious and all that. And then we said, well, you know, what if the person gets a fever halfway across the Atlantic? You know, do you put the pilots in PPE and have them just continue on their way? And the State Department's like, well, you know, we're screwed if that happens. We don't know. You know, this was very new territory. And you know, when they flew this plane to go get the 2, I think I've got a picture of, oh, it's coming up. The 2 people they evacuated from Liberia, the 2 Samaritan's Purse workers that went to Emory, they went and made 2 trips, right? They flew all the way out there from Georgia, flew back to Atlanta, flew back to, and I said, what, you know, bunk bed, something? You got to be able to, and it was an FAA regulation. Couldn't fly 2 patients. So they had to fly back and forth twice. So, and blow 2 of these. Anyway, so it was sort of a brave new world of how do we do this, and how do we get partners, and what's our responsibility to our own people, and what's our responsibility, what if a high government official in Liberia gets sick? Do we fly him out in this? And it's tricky. And obviously this creeps into ethical and moral issues but at some point you have to have a policy based on that. And it was very tricky, and it remains tricky. But finally, as you guys know, I think the response in the end, once it got up to speed, went relatively well. Certainly was much better than the modeling, the predictions of 80,000 cases at best and 1.4 at worst. And I'm not sure that model was accurate. I don't know. Those CDC guys do that a lot. They seem pretty good at it. But it certainly wasn't that bad. And certainly public outreach and education. Early on, the PPE was very scary to people, especially early on where people weren't doing well. So your relative disappeared behind the wall with the men and women in the white suits, and 60% of them died. Those aren't good odds to have people want to seek care. Handling of dead bodies, as we talked about, this was a big issue. Culturally, the culture is to wash the body and embrace the body, and that facilitates them going on, their spirit going on to a different place, depending on your beliefs. But in this region, the belief is that that's part of the process of dying, and that was a big. How do you overcome that? You can imagine if someone came in here and said, "Look, we want to, no more coffee. Coffee is bad. You can't drink any more coffee." I mean, that's obviously a glib example, but you're really trying to get people to change their deeply held, long-held religious and cultural beliefs, and that's very challenging. And burial practices. Cremation was not part of their burial practice. And if you don't believe in that from a religious standpoint, it's hard to convince someone that we need to burn your dead loved one. So this was a lot of messaging and things like that. And finally, Ebola treatment units started developing. And this is inside one of the Ebola treatment units. And there was finally a WHO recommendation. Not sure anything that says the WHO way is a good way to go, but that's debatable. Mixed bag, I guess. Contact tracing, this is a lot of what CDC did, and certainly in this country we're very good at this, and in Nigeria, this is what really stops it. You follow someone for 21 days, the incubation period. If they get sick, you got to go back and follow everyone they've been exposed to. It's simple theoretically, it's difficult operationally, but if done well, it can be done. And again, so this is Brantley. This is not MSF, Samaritan's Purse worker who was brought back first, and I think his bringing it back really brought Ebola literally and sort of intellectually to the United States. And I must say, when they were talking about PPE initially, the initial guidelines were this is just a contact precaution. You don't need big fancy PPE. And part of the reason that I was frustrated that MSF was saying no, we're doing the full meal deal PPE-wise was as the Ebola treatment units filled up, the next solution was CCCs, community care units, which looked like Ebola treatment units, but there was no one there who knew anything. It was basically, or there was one person, a nurse, who would then supervise a family taking care of their patient. And then when those filled up, they thought, well, we'll find an individual household and we'll go to your house and we'll say, this bedroom is the Ebola room, and we're going to seal it off and teach you how to use PPE and go in and care for your loved one. And initially, my concern was you have to say to the mom taking care of their child or the family taking care of their loved one at the CCC, you need to give them the same PPE that you're giving the healthcare worker, right? You can't have a double standard. And I thought, it's going to be just onerous to have someone change into full PPE and their, some uneducated person in a mud hut 4 times a day to go take care of their loved one. It's just not going to work. And obviously, I think my concern was justified. I think I was wrong in the level of, clearly, the United States view and the CDC view on what we needed PPE-wise was an underestimate, and it eventually went up to mirror the MSF approach. But it wasn't that simple. It was also that this was going to affect in-country as well. So Ebola in the United States, as you know, there were quite a few cases. The nurses that got it in Dallas, this was that patient that died, and then the 2 nurses, one eventually went to Atlanta and one eventually went to NIH, and then the one died in Nebraska. But so there were several cases. People that came here and got ICU level care did generally well. The guy in Dallas was delayed, and this guy came to Nebraska already pretty sick. The cases that were recognized early, people did pretty well. And if you look at the Emory experience, they've got quite a bit of experience in this. If you're pretty aggressive with these folks, they can do really well. The question is, do we dialyze people with Ebola, or do we intubate them? At what level? And really, if you are aggressive, they seem to do well. And then, of course, that translates to overseas, where organizations like Partners in Health are saying, well, we need to do that over there, too. We need ICU level care there. And, that's not necessarily realistic. And that sort of started the New York Times war between MSF and Paul Farmer. And I don't have a dog in that fight because, it's sort of I think they're both right. It's how you balance resources and things like that. But the point being is folks in the United States did relatively well. There was a ton of hysteria early on. I think given everything, it was maybe understandable. I'm not sure it's justified. This is where Donald Trump gets all his information, global research. Ebola's linked to the CIA. There were people, does this guy realize he's got more of a chance of getting run over by a bus or get the flu, or in this case, shot by the Secret Service that are standing all over the place? But there was just ridiculous hysteria. Chris Christie was up in arms, and this is the nurse from Maine who, God forbid, went for a bike ride. It was really kind of a little cuckoo. Again, not surprising. People are understandably terrified, but this lady's not going to give the person an car Ebola. So, from a healthcare standpoint, I think that us being terrified was better founded and very real. So this was the initial CDC recommendation. Standard contact and drop-in precautions are recommended for management of hospitalized patients with known or suspected Ebola hemorrhagic fever. And then they went on to describe the basic PPE that we're all familiar with. And then they do say additional PPE might be required in certain situations, such as large amounts of infected fluid, including but not limited to double gloving, disposable shoe covers, and leg coverings. And it clearly didn't work. It didn't work overseas with some of the NGOs, and it didn't work in the US hospitals. So again, the recommendations got bumped up from the original CDC guidelines all the way up to the moon suits, which I think, given everything, are more appropriate. I certainly would not have predicted that, but certainly seems to be the case, which is obviously challenging for us. And then, now the interim guidance for US hospital preparedness, the tiered approach, which is sort of now, this is on the CDC website, I won't go in, but so it's challenging for healthcare workers. In our emergency department, we drilled, but it's like anything. If you don't do it all the time, it's challenging, and especially when you're dealing with something that's potentially life-threatening to you as the care provider or as the lab worker. There are four, I don't know if people know this, there are four hospitals that are level 4 biohazard facilities in the US. The rumblings for this sort of started after 9/11, but these are the hospitals that are considered the highest level of infectious disease protection for highly contagious infectious diseases. One of them is that unit in Emory, actually. And the reason it's in Emory is CDC is across the street. It is funded by CDC, and the idea was not that someone from West Africa was going to come over. It was the idea that some CDC worker was going to break a beaker and go, oh shit, and it's like geeks gone wild, as and I work for CDC, so that's why it's sitting there. Similar for the National Institutes of Health Hospital in Bethesda, NIH is right there, and then what's the story here, out in Missoula? This is an NIH-funded facility.
Isn't there a BSL-4?
Yeah, there's the Rocky Mountain Laboratories in Hamilton, Montana, exactly. Rocky Mountain Laboratory being where Rocky Mountain spotted fever was originally described. And it's named after the laboratory. There's actually no Rocky Mountain spotted fever in the Rocky Mountains. It's named as such. Unlike people like Zika, other people who say, oh, it's in the Zika forest, so let's call it Zika. Oh, it's in Ebola. It's near the Ebola River. Let's call it Ebola. In the United States, we go, oh, the lab is the Rocky Mountain lab. It's not here, but we're calling it that. So that's the American way. But so this is here because there is a NIH lab. It's also here for a reason similar to Nebraska. Nebraska is the biggest unit. They have 10 beds. Why here? And why would you put it in the middle of the country?
Because it's next to your ports of entry, your largest.
Right. But also, you don't want it in a big city, right? Ebola is easy. What if this was a highly contagious respiratory disease? You don't want this in the middle of Manhattan. You want it out in the middle of nowhere, not to offend anyone from Nebraska. But so that's part of the reason. They want these, I mean, they're geographically dispersed around the country, but you don't want this sitting in the middle of an urban area. And it's sort of a fascinating story, and I'll show you an article. But this is the Emory unit. Again, the Nebraska unit's got 10 beds, but this is completely separate from the hospital. Their laboratory, their water system, their electricity, their plumbing, everything is completely separate. So when Brantley got off that ambulance in the moon suit and walked in, this is a functioning as a different facility, essentially. Same physicians, but. And again, just sort of, they've got dedicated rooms in the Emory facility. For when Brantley was there, for every 24 hours of a patient being there, they have 27 providers go through the process and go in the room. And they've never had an infection. And the challenge, that's because these guys in those 4 hospitals, they drill on this all the time. They have the funding to do it. They have the resources to do it. This is part of their practice. And that's, I think, the challenge for hospitals like the UW and Harborview. This is not what we do every day. I'm sure if any of us worked there, we'd get up to speed and we'd be fine. But the Dallas is a great example. It's a big medical center. They were doing PPE, and 2 of their nurses got sick. And they're they're good nurses with, I'm sure, in good infection control practices. I'm sure their hospital has good infection control practices. But this is very challenging unless you do it all the time. This, I think, is the Nebraska unit. But again, this is a dedicated unit. At UW, we had it across the room from the ER, and I mean, it was great. But I kind of look at this, and I was kind of like, it was kind of like duct tape on the walls. And again, I think the response was appropriate. It was timely, which is critical. They got a lot of people up to speed. But when you take a step back, this is really how this should be done. And I think this is the challenge: is how do we scale this down and replicate it across the street? And this is a great Scientific American article. This is from October of 14, talking about the 4 biocontainment units. So if you're interested, it's got some video and stuff. It's a nice article. So moving on. So again, I think the PPE challenge is just that. And I think workshops like this are critical to kind of learning how to do this. But how do you maintain your skills? Do you have a drill once a month? Do you have a should we sort of, we have a lot of disaster drills, but a lot of it is triage and where are you going to put people and neon vests and hats. And I wonder if we need to roll some of this PPE stuff into that. Because I just, having done it myself, both at, for the government and then for here, it is very, as you'll see this afternoon, it is really hard. And, here at least we have air conditioning. In country, when I talk to the clinicians there, you put on the suit, and it's 100 degrees outside, and now it's 140 in your suit, and you're sweating, and you're breathing fast and anxious anyway, because the person you're taking care of has a disease that'll kill you. It's understandable. And when you look at the MSF protocol, they do a lot of misting with chlorine and everything. It takes about 45 minutes to get out of the suit by their protocol. The CDC decided that they weren't going to do misting. They didn't want to aerosolize stuff, again, MSF had a good record. They definitely had people that were infected as well, but I don't know what the right answer is. So other just sort of to wrap up, just sort of other things about Ebola. Brantley and the gal whose name I can't remember both worked for Samaritan's Purse. They got ZMapp. Did you guys hear about? So ZMapp is a monoclonal antibody where they basically take the Ebola virus, to make it very simple. They cut it into 3 parts, put it in mice. Mice make antibodies against that part. They then propagate it on a tobacco plant. I'm not sure exactly, but don't say big tobacco doesn't save lives. So it was experimental. It was done between the Canadian Public Health Institute and a little San Diego biotech firm. And it was not an experimental drug. It had no investigational protocol. But they were so desperate, they said, look, we're going to try this. So they literally, and I know the guys on the other end, they literally flew this vial of ZMapp to Liberia, and Brantley especially was quite sick. And the guys in San Diego and California said, you can't heat it up. You have to let it defrost naturally, because if you denature the protein, we don't know, and we want to make. So they literally had to sit there and watch this thing kind of defrost before they could give it. And they got it, and both survived. It's hard to say. This is not a prospective study. But what was the other thing that Brantley got? You guys know? The answer is. Yeah, he had taken care of a 14-year-old kid. He was just a physician. He was not there for Ebola. He was there anyway and happened to get Ebola. And he took care of a 14-year-old kid who survived. and now had antibodies. So they gave Brantley a blood transfusion from that kid full of antibodies. And again, it's hard to say, but that was not new. This is from the original, this is from 1995 in DRC, and there were 8 patients transfused, and only one of them died. And the overall fatality rate was about 80%. So hard to say. These were also people that were already at the hospital. They could have gotten better care, but certainly that was not new, the idea of giving antibodies from another person. So Brantley got that as well. And then now, of course, the big rush is a vaccine, and there have been some trials. WHO is undergoing trials, and it appears to be fairly successful. You know, the first couple reports were 100%. It's clearly not going to be 100%, but it seems to be a disease that's amenable to a vaccine. So why was there no vaccine before?
Because it didn't matter.
Yeah, because no one gave a shit. Excuse my French. Is this being taped? No, I'm just kidding. But right, there was not the financial incentive. And so at least now there's enough public outcry. And you know, who knows, maybe it'll be a travel vaccine. You're going to work over there, you'll get the vaccine, they'll charge you $600 and it'll pay for itself. But yeah.
Last numbers I saw was that something like 400 or 500 healthcare workers died.
Right.
Do we know, statistically, what were the failures of whatever it was that resulted in them getting it, which I think was 800?
Right.
Do we know what those were?
I actually had a slide about that, and I just decided to cull that. But I think most of the healthcare workers were nationals, not international, so people from, and the sort of infection control practices were just abysmal. My buddy who was there, who shook hands with the guy that died, said he said you'd walk into hospitals in Liberia, and it was like something from a bad movie. I mean, there'd be patients in beds, blood, soot, and no one around. People just abandoned. And part of it was a lot of them had actually passed away. I don't know. I think the failures were probably things that you would just be appalled by. And even since, there have been some cases, and when they go back and when they've looked at it, because a lot of the healthcare workers now, nationals, have been trained, but they've gone back and looked at the cases and they just did not follow the training. And again, it speaks to the fact that it's hard. There's a lot of PPE in these countries now. There's warehouses full of PPE, and there's people that have been trained and train the trainers and that. But when push comes to shove, it is really hard. I imagine someone has looked into exactly what and tried to stratify it by risk. I don't know, to be honest. It's a great question. So a vaccine is hopefully coming. And I think the question is, what next? One of the issues, I do a lot of malaria work, and one of the things that I still think is questionable was, early on in the Ebola outbreak, the decision was everyone that comes in is going to get treated presumptively for malaria as well. And before that, the WHO recommendations were you needed to have a diagnostic test before you treat someone for malaria, because the challenge is if you treat everybody who's got a fever, you end up with drugs that don't work, chloroquine in all of Africa, for instance. But the thought was, well, it's too scary to test them for malaria. My thought was, you're drawing blood. The people come into the ETU, and they're screened, and they're considered at risk. So they get their blood drawn, and it gets sent off to a lab, and they do PCR, and it takes 3 or 4 days at least. Why not take some of that drug, put it on a rapid diagnostic test? If they're positive for malaria, which you know in 20 minutes, start their treatment. And if you're giving them an ACT, artemisinin and combination therapy, it's 3 pills a day for 2 days, 6 pills. So by the time their Ebola comes back, the people that have malaria are treated. That to me still seems like the reasonable way to go. But they were so scared of having Ebola blood not in a level 4 laboratory that they were just treating everybody. And the reality was, during that time in those countries, more people probably still died of malaria. And I don't know the right answer. I still don't think that was the way to go. My feeling is if you can draw blood well enough to put it in a test tube, package it to send it to a lab, you should be able to put a drop safely on an RDT. But anyway, so, and then I think the bigger question is what's next for these countries. I mean, again, going back to the why it happened in these countries and got out of hand is largely due to their failure in governance. These are extremely resource-poor countries with not a lot of infrastructure. And now they're relatively Ebola-free resource-poor countries with no infrastructure. One of my sort of, not complaints, but one of my frustrations with the way OFDA works is they don't support, one of the issues is the development world and the response world don't talk. And the response folks that I work for, I don't think about development enough. You know, you show up in Haiti and you're just there, and then that was 2010. 6 years later, if you go back to Port-au-Prince, it doesn't look all that different, unfortunately. There's some houses built. And one of the problems here was that the US government and a lot of the agencies don't support building permanent structures. This is a temporary thing. And so I'm thinking, gosh, if we had just built temporary, or we'd built more permanent ETUs, those could now be converted to health facilities and, and use some of the money to train, women in these countries to be nurses and doctors, men and women, but especially women, I think, and empower them. And so, how do we prevent this from happening again? And again, it's more than just training on PPE and how do we get these countries to sort of get up to speed. And that's not an issue that's gonna be solved quickly. But I think just, again, I realize that's sort of the international end of it. And I think from our standpoint, I think just attending things like this and practice with PPE and I just, again, Ebola is relatively manageable if it's a respiratory pathogen, like a smallpox type pathogen. It's going to be a whole different world, and hopefully that will not happen. But so I will wrap up there, and I think we've got about 3 minutes for questions, and then I think there was an announcement for 5 minutes, and then lunch. I've got 14:11 left. Anyway. Any questions, comments? Was anyone over in West Africa during the response? No. No questions. Yes.
Am I correct that the plan is to get one biocontainment unit in each of the FEMA regions, or will those 4 still have a different role than the other 6?
Yeah, I don't know. That's a great question. And again, my work is almost exclusively international, but I think there's certainly, since Ebola, a real push that we need to, these things have been sitting relatively idle for years, these 4, relatively. I mean, you don't hear about it, but they do. And all of a sudden there's, trying to figure out where to put these people. So I imagine that there will be both the impetus and the financial resources to probably scale this up, but someone here may know more than I do, I don't know. We're fortunate here in that the Shoreline Laboratory could actually turn around things very quickly in terms of our laboratory capacity, is even locally is really good compared to a lot of parts of the country. So we're sort of fortunate. So, questions, comments, other?
Your DART team, when this all evolved or started to, when did they respond from Nairobi?
It can't happen. I'm trying to remember. Liberia was the first to declare a disaster. Then. Because Guinea didn't until late, so because we can't go unless there's an official disaster declaration. And I'm trying to remember, it was April of 13? Let me think. I'm trying to remember. My boss. I was here, and my boss in DC called and said, "You want to go to Liberia for 7 months?" And I had a 3-week-old at home, so the answer was no. But I was like, either I'll go and survive Ebola and come back and my wife will kill me, or I'll die from Ebola. Either way, no. So that was it was about 21 months ago. So that was January of 14. Is that right? Yeah. So somewhere around early 14. So it had been, again, the early on it was, this is just another Ebola outbreak. It's going to burn out. And then it was, CDC is on this. The Office of Foreign Disaster Assistance does not want or like, we don't like to respond to, in fact, cholera is the biggie. We get called all the time, there's a cholera outbreak, and it's endemic seasonal cholera. And the reason being is that if you did that, you'd burn up all your resources responding to cholera outbreaks, and there's enough. So this was very foreign to USAID. They did not want, so this is CDC, they do this all the time, as they should, they're good at it. And then it became very clear that just logistically, not from a technical standpoint, they had hundreds of people on the ground, CDC. But logistically, it was just not something they could manage. So they needed a DART format. So it probably was January 14. I'd have to look.
Just a question about the PPE. I don't know if this is on.
I can repeat it if.
Anyways, the PPE. So one of the things that caused a lot of that fear that you talked about and the confusion was that the PPE kept on changing. It was almost daily that the PPE was changing. And you'd have you're supposed to have a small session of healthcare workers that were supposed to come and watch our infection control specialists change in and out of this PPE and talk about donning and doffing.
Right.
And then there would be 50 people there because everyone was scared. And then
Sure.
the next day they would have something totally different that they were doing. So I'm wondering, like, with novel pathogens coming out or things that we're not that familiar with, why not start at the top and then go down, like
Right.
scale down? Because when you don't err on the side of caution for the safety
Right.
of, instead of starting with,
Right.
oh, I think you should just wear, you know,
Right.
this and this. I think sort of the same thing happened with SARS.
Yep.
When SARS came, they were saying, oh, reuse your N95 mask because we were running out of them.
Right.
And then other people, they were fighting right in front of us and saying, no, you can't reuse that. You have to just use it once. And they're saying, okay, tape the paper bag to the door and then put it in there. And then when you go back and get it out of the paper bag, put it back on. And so I'm just thinking, like, starting from the top
Right.
when you don't know and
Right.
then kind of scaling down.
Did everyone hear the question about when they decide, why don't you say, look, we don't know what this is, let's start with the highest level of PPE and work our way down to where we think it's safe, versus the fact that we do something and 50 people would train and then all of a sudden the next day, oh, we needed to come back, that was wrong. And that was exactly what happened. Part of it, and that's the MSF approach. MSF has guidelines for the management of hemorrhagic fever, and they wear the full suit. And they, early on in the response, they said, we don't care what everyone else is doing, this is what we're doing, to their credit. And I don't want to blame. I think at the time what they were saying was reasonable, because it is theoretically contact precautions should be enough. You don't need to wear an airway device. It's just that I think part of it is with the full suit, it's easier. It's tricky because part of it is you look at the failure in Dallas. If they had worn full suits, is wearing more stuff, are you more likely to make a mistake, or is it more protective? It's tricky. And part of it also was that what we were recommending, what CDC was recommending here, they had to also recommend to people in country. And now you're obligating that woman taking care of her child. So that, it's sort of a matter of operations internationally as well. There's clearly not a right answer. I mean, you're right. It was not done well, and that was part of the stumbling at the beginning of this, and part of why it was so different. And to CDC's credit, I think they changed quickly and said, this isn't working, we need to up the game, which was obviously for a healthcare worker incredibly frustrating and scary, because it's like, can I believe anything you're telling me, and what if this isn't right either? But that was just the reality of it, is the original thought was truly that contact precautions would be enough. And I think in some cases it probably was, but I think overall it clearly, people needed a higher level of PPE.
Just something to learn for next time.
Yeah.
Because realistically, if somebody's got something and they're being cared for at home,
Right.
I don't know if you could apply the same principles to that
Right.
scenario, because
True.
it's not the same as being in a healthcare facility.
Right. And those four, when you look at the Emory, Nebraska, the Montana, they wear the full, they wear the full suits. And again, part of it is they don't know. The thought is we're not exactly sure what this is. So MSF wears the full suits. Those units wear the full suits, and I don't know. I wasn't in on the meetings at CDC what the thought process was, but I think to their credit, they recognized that it was insufficient and scaled it up.
It's also a lot more comfortable. And the other piece is that when you're wearing the N95 mask, and you're wearing the face shield, and you're wearing the hair covering, and you're wearing the boot covers and this
Right.
and that, there's so many pieces to doff. The
Right.
doffing is the dangerous part.
Yep.
So if you're wearing one suit, one
Right.
hood, it's
I
a
w-
little bit.
I was in DC a few months ago, and there's all this like challenge grant money for people to develop new stuff. Yeah, and it's like Hopkins. We went to this demo at Hopkins, and it was this crazy suit that you literally like one thing, the whole thing. It's pretty good. It was pretty impressive, and like these portable ETUs with copper walls, because copper is antiviral, and all sorts of people have kind of. Well, it's a lot of engineers working hard on this stuff. It's sort of interesting, but the PPE, where it really came off in one, and face shields that don't fog up as much and stuff. So this is an evolving area, and I think where we are now is certainly much better than where we were at the beginning of this, and I think there were a lot of lessons learned both locally and nationally at the CDC level, and hopefully there will be lessons that are carried forward, but then the next one will be something else, and we'll have to relearn everything, so I don't know.
Hopefully there's more proactive action than reactive, because,
Right.
like there was that outbreak in 1976 with Ebola, and nobody did anything, but today's a different day when there's so much, there's world travel,
Right.
there's so many ways for
Yeah.
these pathogens to get around the world that
Absolutely.
they might need to be a bit more proactive, where they're looking at different country pathogens in different areas that maybe would end up spreading greatly in an urban area or something like that, where they need
Right.
to be a bit more like, this is something that's potentially
Right. Well said. And, oh, one last.
Well, I just liked your point about if we treat the current epidemic, but we don't change the infrastructure,
Right.
we're not really changing the long-term picture.
Yeah, public health is an economic discipline. You know, I mean, it's a sad reality, but you know, countries, and they're poor for different reasons. You know, a lot of it is failure of governance, and some of it is corruption and inappropriate allocation of natural resources or lack of natural resources. But you know, you can. It's a lot of public health becomes a Band-Aid, and if you don't have an economy, you know, we used to have malaria in this country. We don't anymore, and it's because we have a robust economy. And Nigeria is a great microcosm example of if you've got an intact health system, these diseases are relatively easily controllable, and if you don't, they can explode. So, all right, you guys are into your lunchtime. I think there is still an announcement before lunch. And
So thank you very much.
thank you.